So hello, good morning, good afternoon, good evening from whichever part of the world you're from. Welcome to the third webinar series of the International League Against Epilepsy and the AO subsection. And on the behalf of my co-convener, Professor Kawai Kensuke, and the chair of ILAOE, Professor Akio Ikeda and Professor John Dunn, we welcome all of you for this one more session of an exciting session of webinar on cortical dysplasias of the temporal lobe. So let me go ahead and share my screen so that I could show you today's program and how would be the workflow for today's program. And we hope that you will be able to enjoy this as much as you did for the other previous two sessions. So we will start off this session with a case presentation from Manjari. And this will be followed by a couple of slides, surgical slides, to show what we have done for this case, as this happens to be the soul of this meeting. And we will have a detailed interactive discussion with our faculty, very esteemed faculty, Dr. Simon Harvey and Dr. Virginia Maxner from Melbourne, who have been very kind enough to join us for this session. And then we would have a interactive discussion with the audience with the questions taken from them. And then we have a couple of very exciting lectures being given by both of them. So Simon would be speaking on principles of localization of surgery in drug-resistant temporal lobe epilepsy. And Virginia would be speaking on case presentations from Royal Children's Hospital, Melbourne. And this would be again followed by question and answers, followed by conclusions and summary. So this is the third of the webinar series. And our objective is to cover every aspect of the fundamental aspects of epilepsy surgery. So we started off with the right temporal hippocampal sclerosis, went to left hippocampal sclerosis. And now today we will be dealing on the cortical dysplasias of temporal lobe, which do have a unique pattern. So this is my slide. So at the outset, let me have the pleasure of introducing my co-chair, Professor Kensuke Kawai, who is a professor of the Department of Neurosurgery from Jiji Medical University and the Vice Director of Jiji Medical University Hospital. He currently holds a key position in the AOILE, and we are I'm quite happy to have him as my co-convener, and we look forward for an exciting webinar today. I would now also briefly speak about Professor Akio Ikeda, who is currently the chair of the AOILE. He was a president of the Japan Epilepsy Society. He's a professor of Department of Epilepsy, Movement Disorders and Physiology, Kyoto University, Graduate School of Medicine, Japan. Now, aside from his teaching and clinical roles, he is involved with numerous professional bodies. He is the incumbent member of the Japanese Society of Clinical Neurophysiology and holds various council and committee member positions in Japan Neurological Society. He has been working on the clinical epilepsy wideband EEG and the role of glia in epileptogenesis, and has earned his PhD from Kyoto University in 1993 with his thesis on movement-related potentials recorded from supplementary and primary motor areas of the brain. He has published in the literature more than 380 original articles. So under his leadership today, along with Professor John Dunn, we've been able to carry out this webinar series. Professor John Dunn, unfortunately, was not able to join us today, but he sends his best wishes. So he graduated from the University of Western Australia. He did his clinical neurophysiology, EEG, epilepsy fellowships at the Mayo Clinic. Currently is a professor, Department of Medicine, University of Western Australia, Secretary General, ILE, Oceania, AO, Asia Oceania. He's a chairman of Western Australian Epilepsy and Adult Clinical Neurophysiology Services, member of Epilepsy Society of Australia, National Executive and other committee. He has published more than 100 peer-reviewed publications, and he has won the AOEC Outstanding Achievement Epilepsy Award in the year 2014 and the Ambassador of Epilepsy Award in 2019. So I would now request my co-convener, Professor Kensuke, to say a few words, and this would be followed by a few words from Professor Akio Ikeda as the chair of AOILE.
Okay, thank you. So this is Kensuke Kawai from Japan.
Thank you very much, Professor Kensuke. Professor Ikeda?
Yes, good evening, everybody. I'm very honored to be here to attend this session, epilepsy surgery case by case and step by step. It is the extremely important opportunity for all of us in the Asian Oceania area, because that COVID-19 has been impeded quite a lot of things, but nevertheless, of this opportunity at Saturday night can provide us the quite important opportunity, and that would be one of the fun for all of the people. So I'm looking forward to having today's discussion, especially by the guest faculty, Professor Simon Harvey, and then the Professor Virginia Maxner. So it could be the very fruitful discussion. At the end of my just a brief words, I'm very pleased to announce that the Professor Kawai has been assigned as the new president of Japan Epilepsy Society after my completing of my term of 2 years. And also, I as also the past chair of the ILE Asian Oceania, and currently the chair is that the Professor John Dunn. So we have been and we will be working on this activity together. Thank you very much.
Thank you so much, Professor Ikeda, and congratulations to Professor Kensuke as well as to you for hosting a wonderful session. Let me share my screen again. So before I give over the podium to Professor Kensuke Kawai, a word of appreciation to our sponsors who have supported this initiative through an unrestricted educational grant, and we are very grateful to them. So Professor Kawai, you may now take over. So we will first start with Manjari's case presentation. So you may first introduce her, and then later on you could introduce Professor Simon Harvey. And
okay, I think I can start my presentation. I've been introduced before. We'll save some time.
Okay.
But let me introduce briefly. So, the Professor Manjari Tripathi is a famous the professor in neurology, All India Institute of Medical Science. So she is now is a ILA task force member for stigma in epilepsy and pediatric epilepsy surgery subcommission. So she is very suitable for today's session. And so, she's the Secretary General of Indian Epilepsy Society. And of course, she has a huge number of actually 318 research publications. Looking forward to hear the Professor Manjari Tripathi's presentations. Could you start?
Yeah, thank you. Thank you all for organizing this meeting. And I wish during my days of training, I did have such a forum to learn from. Nevertheless, better late than never. And I think with each case, I learn a lot from all the invited, experienced neurologists and epileptologists all across the world. Can I share my screen now?
Yes, you may.
As said, I'll be discussing this young cherubic girl. She was a very sweet 4-year-old, almost 4-year-old. And she came to us with, seizures, which were obviously refractory. And that's why she's being discussed here. And the seizures mainly started at a very tender age of less than a year, at 11 months of age. And they were there for almost 3 years before she came to us. Initially, she would have a number of them. She would have almost 20 to 15 events in a day. And when she came to us, she was on X number of anti-seizure drugs, and they had reduced to 3 to 4 per day. There was a history of clustering of these events, but there was no chronorhythmicity in that they did not occur only in sleep or any particular time of the day just after awakening. So she had a normal, birth. She cried immediately after birth, but there was some, mom said that she had some grunting sounds and she was put on oxygen for an hour or so. She normally developed in terms of her social smile, her sitting, her blabbering till 11 months of age. At 11 months of age, when the seizures started, almost 20 in a day, she had a setback of all the milestones, and in fact even lost her monosyllabic speech, which she picked up later. So the milestones were primarily delayed after the onset of the seizures, and they did improve a little bit when the control of the seizures happened on the anti-seizure drugs. Her functionality when she came to us was that she could walk independently up and down the stairs, but she needed support. She couldn't just go off on her own. She could eat with a spoon, but would spill, and so her mom had to assist her. She would imitate her grandparents, and she was a happy child, but irritability was increasing with the number of anti-seizure drugs which had been on her. And she had become a little dull as compared to previously. When she presented to us, she could just speak about 2 words together, but she would manage to communicate to her parents. Her Hague seizure severity scale was 36, and her Binet-Kame test showed an IQ of 73 with a mental age at 39. Childhood behavior checklist showed scores of 74, and they were definitely impacted quality of life scores. So this was how she was, but the history given to us for the seizures was mostly of events which were occurring in clusters, and somehow the semiology slide has got cut here, which the parents gave us. I can describe, the parents told us that she would have events where she would just kind of go vacant and blank and stare and sometimes move her lips. And her left hand would used to be outstretched. And occasionally she would shriek. She would not have any aura. She would not indicate that she's having an event. And these events were usually brief, particularly after starting the anti-seizure drugs. They lasted for just, a few seconds, maybe 10 to 15 seconds, but sometimes they would be prolonged, lasting for a minute or two. So that was the semiology given by the parents, and the only lateralizing feature in the semiology was that the left hand would go out. Apart from that, there was some movement of the lips, which the parents told us. There was no history of any head injury or any febrile seizures, or no prolonged admissions to the hospital prior to the onset of seizures. Of course, after the seizures onset, she had multiple visits to the emergency rooms. She had come to us after evaluation at 2 other centers, with MRI, which was tagged as normal. She was on multiple drugs by the time she came to us, and the parents were very, very hesitant to eliminate any of these. So she was on these when she came to us last year. You can see here she was on almost 7 drugs. She had also received immunomodulation or immunosuppression with methylprednisolone and steroids because at one point of time, entity of probably autoimmune was also entertained on the kid. So with this history, the hypothesis was, of course, that she was having drug-resistant epilepsy, and she came in with a semiology which didn't show any nocturnal predilection, but the seizures were in clusters, and there was a lateralizing finding in the history, which was abduction of the left hand with some oral movements. So since the events were these, our hypothesis, even before we connected her to the epilepsy monitoring unit, was probably a temporal onset. But one couldn't be sure because in children, even posterior pathologies like occipital could rapidly propagate, or even pathologies or etiologies which are in the frontal, mesial frontal, or posterior frontal could kind of get into the temporal cortex. Though she had abduction of the hand, that would go towards frontal. So mostly the hypothesis was temporal. Frontal was not so much because there was no event in sleep. And, this is just to show you the other workup which was done. She had a metabolic screening. She had a genetic screening prior to coming to us because she was tagged with a normal MRI, and she had an extensive autoimmune workup, the NMDA, MOG, everything was done on her. Though there was no history of febrile infection before, or febrile episode before the onset of the seizures at 11 months of age. And 11 months is really, probably the youngest I would see. So with this, we got her into the epilepsy monitoring unit, and she had several events over a very short span of time. Really didn't need to taper the medication. So her mom is there with her. You can see the left hand go out, and then she has some burning. She just stares and then blinks. And then she tries to get up with kind of a flexion of the body. And that's the event. And if you look at the face, there is some, there will appear some oral matter. So there are some oral objects which have appeared now. She's looking at the toy. She looks at the toy. So the nurse took the toy in various directions, and she actually stared at the toy. There is some kind of partial responsiveness, though the oral movements continue. Now, children nowadays like to play with mobiles more than toys, and just like any kid, she was most used to the mobile. So the mom said, give her the mobile. She didn't reach out for it, though. Normally, she reaches out. And there is a yawning at the end of the event, kind of yawned at the end. Still not reaching out. And the event is kind of over. And she just rolls in, goes to the side. So we go to the next event. Trying to respond. The mom is asking, where is Papa? She's responding by vocalizing and trying to show where the father is. So now her responsiveness is gradually returning. The other event, they're drawing blood for testing of sample levels. And then they realize she's had an event. And again, Her right hand moves. Her left hand doesn't move. It's outstretched. Right hand kind of moves around. She flexes it. And then she looks around. And the event is getting over now. She takes a little bit of time coming back. And the oral movements are there. Here are some oral movements. Not still responding. Oral movements continuing. So oral movements continue for quite some time. Another event. Again, the left hand goes out. The right we cannot see here. She's a little unsteady. The mom realizes there's an event. The nurse is not able to make out whether the event is over or not because there's nothing else happening. So this is the event in which the ictal speculum, and she kind of brings her right hand forward. The ictal ECD is being injected. So pretty much those are the events. And with this, I'd like to discuss the events first. So is that okay, Simon? Hello?
Yep.
Okay.
Like me to comment on the video?
Yeah. So basically what I thought was that in these several events, there were some in which she had her left hand flaying outside, and then there were some perioral movements. And in two of them, there seemed to be a tonic component to the event. What would you say about the events, Simon?
Well, the video didn't seem to match the history the parents was giving, which is often the case. So the mental picture I had from the parental history was of bland staring with some automatisms occurring many times a day. I suppose initially you'd think of just absence, but that was obviously excluded. Looking at the videos here, the striking feature is this sort of sudden asymmetric tonic posturing. So they're brief episodes with sudden extension of the limbs in an asymmetric fashion. The impression I had following that was of maybe a prolonged postictal phase where she had oral automatisms, maybe as a postictal manifestation. And the video wasn't playing smoothly for me, but I wondered if there was even a couple of spasms, epileptic spasms, in that sort of prolonged period of unresponsiveness with the automatism. So, if I was seeing this child for the first time, I wouldn't be thinking temporal lobe epilepsy, and I'm sure this video is nothing like videos that were shown in the previous two webinars on epilepsy with hippocampal sclerosis. So this, to me, looks like a child having tonic seizures, maybe with spasms, and onset that was quite sudden at 11 months of age with regression. So I'm thinking this is some sort of symptomatic generalized epilepsy, an evolving Lennox type problem, recognizing that it may well have a focal basis, and which is presumably why we're discussing this child. We shouldn't sell this as a typical temporal lobe seizure by any stretch. It's a seizure that could have many etiologies.
Yeah. So we were also kind of flummoxed by her the mismatch between the history and what we observed. But what goes for sure was that there was some tonic event there, which was definitely asymmetric with kind of extension of the left upper limb. And there were prolonged oral automatisms. So keeping this in mind and keeping the fact in mind that these were not very brief events, they were rather prolonged events, and there were oral automatisms. If you look at lateralization, we would tend to err towards the right hemisphere. And if we really had to be pinned down to localization, it would be difficult. It looks like a SMA kind of thing, or a frontal lobe. But there was this asymmetricity, so definitely going to the right. And there were prolonged oral automatisms, which could be explained by either temporal or insular or frontal opercular involvement. Simon, do you think that was a reasonable line of thinking?
I think if you're viewing this as a typical, older child focal seizure, sure, you can chop it up into those elements. But I think, seeing this child's EEG is going to be important. Does this child have some sort of generalized epileptic encephalopathy going on? Because I think the main thing here is the regression. This child had profound regression from age 11 months with this seizure onset. This is by no stretch typical, medial temporal lobe epilepsy in a child. This is a very urgent sort of problem that needs sorting out promptly. And just with that history and these seizures, I think would take people down all sorts of lines of thinking. So I think an EEG is important here, and if these are shown to have focal changes on the EEG, then maybe we can, start inferring some localization from those. But I think it's very difficult. Automatisms and an asymmetric posture. Sure, I'd favour right hemisphere, but I think the EEG is going to be more compelling than dissecting this child's the physiology of that sort of seizure.
Yeah. So, it is difficult to kind of try to localize and lateralize with those kind of phenomenology, but children less than 6 years very often may have very subtle lateralizing features, and they may actually present with generalized semiologies, even with focal lesions. So we still didn't know what we were chasing, whether she was a lesional epilepsy. She'd come with everything negative, MRI negative, which was done at, around 1.5 years of age. She'd come with all autoimmune, metabolic, genetic things which were negative. So the interictal EEG showed us this.
Manjari?
Yeah.
Would you like to ask the opinion of Professor Ikeda also? We have two neurologists on board.
Yeah. Any comments from the panel?
Okay, could you hear me?
Yes.
Yes, I essentially agree with the comments by Professor Simon Chauvin. Initially, when you mentioned that the patient have the cluster and the seizure, with that no coronal rhythmicity, I imagine that the patient may have some sort of flavor of epileptic spasms. But when I look at the video, the flavor of epileptic spasm is not so clear. But as he mentioned, that the so-called fencing posture with the asymmetric tonic posturing, which all suggest, as he said, that the SMA seizure was something arising from that the presumably right frontal, but the which is the contradictory thing is that it is so long, and also the coming in clusters. So when we look at this finding as the frontal lobe epilepsy, it is not so typical as the vice versa in the temporal lobe epilepsy. So at the age of 11 months at the onset, I'm just wondering that the patient may have some sort of some atypical feature of some partial epilepsy and generalized epilepsy. I would like to remind, that reminds me of some sort of ring chromosome 20 syndrome, which is the prolonged and then the cluster in some way. As you mentioned, the patient is quite long post-ictal, but it may be some sort of flavor with the seizure. So therefore, although the ring chromosome 20 syndrome is a so-called atypical absence-like seizures, but I would like to exclude that the possibility of the ring chromosome 20 syndrome at this moment. That's my comments.
So yes, she had no history of status, which we often see in this ring chromosome 20. She also had a genetic karyotyping done, which excluded a ring chromosome 20, and she had a clinical exome sequencing done, which excluded any other genetic etiologies, which is quite expensive in India, but they managed to get it done. So, we definitely did think of genetics to be involved, especially when she came in with a negative MRI, and that's why a genetic screening was done. So I go on to any other comments from one?
This is Kawai.
Yeah.
Let me make one question. So how was the eye movement? So you said she was looking around, so there was no conjugate deviation, eye deviation.
No. So
okay.
at the beginning of the event, what the staff nurse notes had noted, because we didn't have a zoom-in camera on the face, it was that she would just look ahead and then she would just move around. So initial few seconds, she was just looking ahead, and that's probably what the parents thought was a stare. And, so she would just look ahead and rest like that, and then her eyes would move around. So we did not have any forced gaze deviation at all in the semiology.
And according to your presentation, so IQ DQ was 73?
Yeah.
Right?
Yeah.
So that sounds very kind of preserved as a symptomatic generalized epilepsy. Don't you think so?
So it was, it was moderately impacted. Though the parents, if you look at the history, they would just say that she's unable to do anything. So I think there was again a mismatch there between what the parents said and what was evaluated. So.
Okay, so those kind of things suggest, a kind of focality, and the more temporal than frontal.
Okay, so the interictal EEG done here, of course, just that is ending of one pulse and starting of another, showed us this focal brief burst. It doesn't look so focal in that it's not regional, or it's not like around just one electrode. It seems more hemispheric, or it seems more lateralized to the right hemisphere. And the left shows, definitely lower amplitudes and no polyspiky nature. There's some suggestion of reversal at F8 and F4. And the background is really slow. She's going to be 4, so the background is pretty low amplitude and is slow. It's probably just appropriate for her age. And again, you see those runs happening after the photic is over. So the interictal EEG showing pretty much this, and it was like brief bursts of 2.5 to 3 seconds. The ictal onset showed us this in a bipolar montage. So pretty much the similar kind of burst appearing, almost the whole right hemispheric. And few sharps appearing before that. And towards the end of the epoch, you see the last 2.5 seconds showing the discharge. And then the discharge continues to the first second of the next epoch. And this is followed by, rhythmic delta to theta, almost to theta slowing, which comes in with a little bit of sharps and, slow. So again, this is what it showed. And then it further evolved into something like this, with kind of reversals around T4 as we move along, and maybe a little more anteriorly also. And then it further evolved into this brief spikes appearing amidst the slow. Then goes on to a slow rhythm. The next event was, done on a bipolar transverse circumferential montage. Sorry, so you can see the reversals at F8 over here, and it continued like this. There's this polymorphic delta around T4, which comes in. So there are these reversals, and there are these, almost generalized looking spike and waves which are seen. And this is followed by this rhythmic, little higher amplitude delta on the right temporal. Doesn't look a really glaringly lateralized kind of ictal onset in this particular event. As you can see, it evolves like this, where you see almost a diffuse spike and wave, and sometimes an attenuation, slowing, and then it goes on like this, and then further goes on like this, where you're seeing almost, it's like rhythm has gone posterior now, and then slows, and then goes along like this. So this is the next event. This is the next event, third event, where again the onsets, really you can't probably would say that there is some generalized spike and wave occurring here, and then there is this kind of attenuation which happens, followed by large amplitude slow, and it goes on. Nothing very glaringly lateralizing on this, and this was the event where this is probably the last event where the mom was sitting on the bed. And you can see here, this is bipolar montage, double banana now. So you can see some, we have the anterior temporals in place, a T2 sharp reversal, followed by these kind of spike and wave and slow, which seemingly, may have a better preponderance on the right side, but also seen on the left. And then it evolves further. This is the event in which the mom is by her side and then gets up. And then it further evolves like this. So pretty much event goes on like this, pretty prolonged, and terminates here. So this is the last event where the ictal spect was done. And here you can see again, there are some sharps seen at T4 and around the right F8, and then it evolves like this. So this is the ictal spect event, and pretty much terminates like this. So this is just the Laplacian montage, which we did post-acquisition. And this is again on the beginning of the episode of the ictal spect event, and you can see the sharps around maybe T4 and around the right. So this is pretty much the last ictal spect event. So any comments on the EEG? Simon, Dr. Kensuke, take it up.
Yeah, again, I don't think we should be trying to sell this and make this into a focal seizure. We're looking here at, we've seen, video of a child suddenly bilateral, tonic, or okay, in an asymmetric fashion, and then in a period of unresponsiveness, prolonged period of unresponsiveness following. And here on EEG, we're seeing bursts, quite diffuse bursts of low voltage fast activity, followed by activation of slowing and spike and wave afterwards. And, I think I presume that the stiffening phase accompanies the low voltage fast here, and the periods of unresponsiveness are associated with the slower EEG, with all the epileptiform, all the spike wave paroxysms, many of which I was having some difficulty following the montages, but many of which were certainly, bilateral, if not frankly generalised. So I think, we should call a spade, and this child has got a symptomatic generalised epilepsy phenotype, not a temporal lobe epilepsy phenotype. Now, it may well have and we should be highly suspicious of this having a focal basis, but we've seen some asymmetries clinically, and we're seeing asymmetries again here on the intraictal and the ictal EEG. But the electroclinical phenotype is of a hemi-SGE here, or a symptomatic generalised epilepsy. We're not seeing focal ictal rhythms. I wouldn't use the word evolve to describe anything. I think it changes. There's a dramatic change. There's the diffuse, all the right-sided low voltage fast activity, and then all this right-sided all bilateral spike and wave of very low irregular frequency. So I'd be very suspicious that this child has an underlying cortical dysplasia as the basis of it, and presumably in the right hemisphere, given what we've seen. But I wouldn't like to put any money on whether it's frontal, temporal, or posterior.
Okay. So it is definitely a difficult conclusion to make by any means. Dr. Ikeda and Dr. Kensuke?
Yes, could you hear me?
Yes.
Yes, when I look at this EEG, first of all, you showed that some burst of polyspike, mainly on the right hemisphere. And the other one, which you showed that some expect that patient have some sort of not the burst of polyspike, but some sort of short rounds of the spike activity, bilateral or mainly on the right side. So when I look at this EEG, as some Shobe mentioned, that it's not likely to be the low voltage fast activity, presumably coming from some certain area. So the ICTA pattern is a little bit quite not stereotypy, but when we consider the patient suffered from the cortical dysplasia may generate some sort of red spike, which can make this an almost continuous spike and wave complexes even in the intake period. But this patient have quite frequent spike, but that is some sort of quite irregular, but mainly on the right hemisphere. So if the patient had the lesion, it could be much more widely distributed with the scattered density, presumably located at the right hemisphere, most likely at the anterior quadrant. That's what I feel at this moment.
So maybe my comment is should be made after the presentation of operative outcome. But I think important thing is, of course, the Simon's comment. I agree, and the important thing or very difficult thing is before surgery. We can distinguish those apparently generalized pattern from a real generalized pattern, and because that decision is important for the surgical indication, and maybe we better discuss after the presentation of surgical outcome. Is that okay?
Yeah. So she had two imagings done at our center, and I told you she came with one, which was done in Mumbai, and the one she came with was read as normal. And she had an imaging in 2020 and then just in the beginning of 2021 prior to her intervention. So the one in 2020, I'll just scroll through it. So going back again.
So Manjari, you could put it on the play and then pause at different specific intervals.
Okay.
So they could have some time. Can press it again.
Okay, so maybe
press that again. Yeah. Now you can press at any point so that the sections would remain for some more time.
Any particular area you'd like to see?
On these cuts now, you just start to see some difference. Well, not so much lower down. I think but flare images are difficult, obviously with a young age and then different scanners. You get these odd hyperintensities and things, but those mid-level axials do seem to show a slight difference in the signal in the white matter. So on the right, so there's poor, so you see better myelination on the left there where you're pointing out. So the dark signal of the white matter going out like fingers going out into the gyri looks relatively normal, like up the back. But over in the right lateral temporal lobe, you're not seeing that well. It's all a bit sort of smudgy. And that's present over, I think, the next couple of slices as you go up. So I'd be suspicious of subtle dysplasia in that right temporal lobe. So you can see if you compare the temporal lobe to the occipital lobe, they look similar on the left, but they look dissimilar on the right. Right, and then you compare the right and left temporal lobes, and they look dissimilar. I think there's abnormality in that right temporal lobe.
Okay, I can hear.
Yep.
So the posterior parts virtually look, very much similar as Simon said. And when you look at this area, you compare it to this area, you definitely see arborization of the white matter here, but you don't really see it working out here.
Next steps to look sort of further forward and ask, is that present in the insular and is that present in the basal frontal lobe? And as we're coming up through the frontal lobe now, you wonder even if there's a little bit of asymmetry there as well between the two frontal lobes. So not so dark, not so dark on the right compared to the left, looking at the white matter signal. So in the frontal lobes, it's a superior temporal gyri. If you go forward into the frontal lobes, they look they're similar. Looks like similar changes in the right frontal lobe as in the right temporal lobe, and so this whole electroclinical presentation is highly suggestive of a subtle dysplasia, potentially a type 1, potentially even hemispheric or quadrantic, maybe lobar, but could be multilobar. So you can see now, just going through that right, there's a slight difference between the right and left frontal lobes. It's not too dramatic. You see there, just the white matter signal is more normal on the left. And further back in the frontal lobe, yep.
So this is just the T1. You want to see the T1s too?
Yeah, I don't think it's going to be something that you're going to nail on T1. It'll be on T2 and flare, looking for subtle differences at lobar level in white matter signal, grey-white distinction, maybe volume. So some of these abnormalities, there's a slight hypoplasia of the affected lobe. So down that basal temporal there, just around, there's bright signal. So potentially, you're looking at, you can see white matter is appropriately myelinated in the parahippocampal gyrus and the fusiform gyrus on the left, but over on the right, it's quite poor, and there's that bright signal there. It is an area that's prone to artifact, but the artifacts you typically see, bilaterally, so that I suspect is pathology. Across multiple slices, yep. You can wonder if that hippocampus is a little bit bulky and bright. Maybe not.
It could be compared to the left, yeah. It does seem to be.
You can see the parahippocampal gyrus looks okay there. So you can see that nice dark line coming in on the right there. So maybe this abnormality is petering out as we get further back, because that's looking more normal. But the fusiform gyrus doesn't, and the inferior temporal gyrus.
Okay. So T1, Simon, you would like to see it, or?
Oh, probably not. I don't think we're going to see much more on. It's not like we're going to be looking for focal sort of cortical thickening and things like that.
So yeah,
a PET scan would be very useful here, and.
So we did feel that the white matter was much better made out and the left temporal as compared to the right temporal. There was some signal change around the hippocampus here, but it was lateral. And definitely there was a signal difference between the left temporal and the right temporal. And this was seen again here. You could appreciate the white matter arborization into the gyral spaces, and it was missing out here. We did not think there was anything, much difference in the frontal, white matter between the two. So our area of interest was the right temporal, and that's what our neuroradiologist concurred with. And this was her ASL, which was again right temporal. But if you look at the hemisphere, that's what made us wonder if it was, as Dr. Kensuke and Dr. Ikeda and Simon said, that is it something just much more than temporal? Is it something which is hemispheric? It was almost virtually the whole right hemisphere. The ictal spect showed a very nice localization to the mid-temporal lateral neocortical structures going a bit mesially, and this was the syscom. So this is what her ictal spect done at the last Caesar, which I showed us. Her PET, however, showed extensive abnormalities. And you can see here that almost the whole temporal and also the frontal opercular. And it was going more posteriorly, almost centroparietal. Though structurally, we did not appreciate any differences in the centroparietal in the imaging. A MEG by Dana analysis, equivalent current dipole modeling, showed us a cluster again in the mid-temporal and superior temporal. It wasn't a very tight cluster, and it showed the propagation of the spikes detected showed origin probably around this area going backwards. So this was a spike propagation pattern which was seen around the temporal lobe. To see it a little more clearly, from the red to the green would be the propagation. And her Esloretta-Curry analysis showed us, again, the superior to mid-temporal area taking up. So this was essentially her workup with us. And With this available workup, how would we proceed? In a resource-limited setting, of course, she has no deficits, no motor deficits. She does not have any grip weakness. She doesn't limp while walking. She kind of walks normally. And there was no paresis, though the ictal spect on the syscom showed a pretty great localization onto the temporal. The PET showed an extensive hypometabolism. So Simon and Dr. Kin and Dr. Kensuke, how would you take her forward? Like, would you do?
Again, I'll just keep restating, I wouldn't be looking at her as a purely focal case. So I wouldn't put too much weight on, I mean, that ictal spect I was quite surprised about. The MEG looks, very localized. It's a bit discordant with the MRI. The MEG and the spect suggests the changes are more lateral, but the MRI suggested the pathology was more basal temporal on the right. A lot of those PET changes, the bilateral PET changes, I suspect reflect the degree of epileptic encephalopathy this child has, the developmental delay, the slowing in the background, the bilateral interictal discharges. So you'll commonly see bitemporal, biparietal, bifrontal, so association areas being down. I think what's important in these cases is to look for, okay, what's asymmetric, what's more on the right. And I would be concerned about the insula and the operculum on the right. That is unilaterally hypometabolic compared to the other side. So I think there's a lot saying that pathology in this child is likely to be much more widespread, certainly in the temporal lobe, if not also including opercular and frontal regions, than just the MEG and the SPECT would suggest. And that goes with this presentation. As I said, this is not a child who's presented with an aura and staring and then automatisms and the typical adult type evolution of focal symptomatology and a focal ictal rhythm. This is a child who's much more in the symptomatic generalized epilepsy camp, albeit with lots of asymmetries and focalities. So I think the dilemma here is going to be how are we going to sort out? There's no doubt this child needs a temporal lobe resected. And I think the discussion is going to be whether you're just going to do a temporal lobectomy on this child and see how she goes, or are you going to try and understand the possible wider involvement of whatever this underlying pathology is, presumed dysplasia. These are tough cases.
May I say?
Yes, Professor Ikeda.
Yes. Based on this kind of finding, I personally feel to go to the standard temporal lobectomy on the right side. The reason is as follows. This is the 4 years old, the children who quite well show that the presumably focal cortical dysplasia, at least in the left temporal area. So in this age, I'm very much curious that why the patient didn't develop that so-called tonic spasm. This age, this seizure arising from the temporal area can easily spread to the brainstem, making some sort of the spasm. But she didn't. But this activity may propagate to the ipsilateral temporal, ipsilateral frontal, or even the contralateral frontal area. So that could be one of the features that the early young child could show that the easy propagation to the other areas. So I had the similar cases, which we published in the case report, Epilepsy 1997, who showed that the quite large, the left temporal focal cortical dysplasia, but she shows that the only tonic spasms as a cluster, but only the ictal DC shift can shows that the focality. And then we made that the standard temporal lobectomy, all the seizure has gone completely. So although this patient usually would develop that the brainstem involvement of so-called cluster of a tonic spasm, but she never did it. But I don't know why. But it presumably can spread to that the frontal of the ipsilateral contralateral side. So only the way which I could suggest it to make that standard temporal lobectomy on the right side. This is the non-dominant side. That could be one of my comments at this moment.
Thank you, Professor Ikeda. Dr. Virginia, you would like to say something? Do you agree with Simon, or would you have a separate viewpoint as a surgeon?
So I do agree with Simon. I think the MRI, particularly the flare, shows very extensive temporal changes, and I have similar concerns about the frontal and the insular cortex. It looks a little bright on the insular, which means that it's a question of extent of resection. Now, I would defer to Simon, but I'm not convinced a limited anterior temporal lobectomy would be sufficient. And I suspect we'd see much more extensive changes if we monitored intraoperatively. So I'm not clear of my boundaries yet.
Dr. Gensuke?
Yeah, and yes, the posterior border of the resection is difficult to decide. So I was wondering. I agree with standard temporal lobectomy, and the normal gray-white contrast was the very posterior. So I was wondering how far posterior we go the resection. Maybe according to the intraoperative ECOG or something, but I'm not sure at this point.
Okay.
Thank you very much. So Manjari, could you show the surgical slides?
So I will just go on to, the time is almost up for the case. So we did go back and forth. I think we discussed it at least 4 times before we came to conclusion that after discussing with the parents that, we would probably want to limit ourselves to the temporal lobe, and there is a possibility that, later on she may have a recurrence which would require further investigations. But so far as what we thought was to limit ourselves to the temporal lobe. And with this, and the parents agreeing for a limited resection, they were not agreeing for a multilobar resection with large, a large craniotomy. And after counseling the parents for many hours, the surgical team and all of us together, and our colleagues in the team, we went ahead with a standard right temporal lobectomy. And this is just to show you the intraoperative electrocorticography showing, you can see the amplitudes here of these spikes which are happening. And I think Dr. Chandra will go on with the surgical resection.
So from the surgical perspective, the child, the surgical team at least felt that he had a hemispheric syndrome. So he had hypometabolism involving the frontal lobe. The posterior boundary of temporal lobes were not made out. There was some suspicion in insula. So we had 2 options. One is that we do a temporal lobe resection and go as far posteriorly as possible, tracing out PET hypometabolism, what we have seen on the lateral side, based on electrocorticography, and then counsel the patients for the possible second investigation. Or at the first instance itself, we do an extensive SCEG. So we can put electrodes in the frontal, in the cingulate, in the insula, and then map out the entire networks. We were kind of hesitant for the second option for a couple of reasons. A, we felt that if we remove a more localized area, we would have a better idea of localizing with SCG at a second stage. Secondly, of course, the parents were not too keen for an extensive resection and for an extensive investigation. And they were ready to decide for a second surgery following a temporal lobectomy, which is extended behind. So we did a fairly large craniotomy, and you can see we went behind the vein of Lobe. So could we go to the next slide? And of course, when we did the electrocorticography, it was almost stage 4. There were runs of spikes coming from all over. Next. We first performed the anteromedial temporal resection. And then when we placed the electrocorticography posterior to the vein of Lobe, it was still grossly abnormal. even though there was some improvement, but still we were seeing gross abnormality, as you can see in the slide. Next. So we went ahead and did a resection behind the vein of Lobe, preserving the vein of Lobe. We went almost up to the temporo-occipital junction. And then following this, when we placed the electrocognitography both superiorly and posteriorly, next slide, we found that it had improved quite significantly. Now, that doesn't mean that we have managed to resect out the entire epileptogenic networks, but it did give us a certain feeling of confidence that we have resected the major networks. And if the child does have a recurrence following surgery, we would be in a better position to know where the focus lies, and we could perhaps do an SCG at a later stage. But fortunately, following surgery, she had a class 1 outcome, and she's doing pretty well. We have counseled the parents that there could be recurrence of episodes, and we're continuing her with full anti-epileptic drugs. But finally, yes, we did a temporal lobe resection and extended the temporal lobe resection posterior to the vein of Lobe, almost going up to the temporo-occipital junction. And with that, the child seems to be doing pretty well as of now. Her psychological measures have also improved significantly, and we are following up the child closely. And the histopathology has come as type 1 cortical dysplasia.
So I think we're time up for the case discussion, and I'd like to thank all our colleagues here who contributed to the case workup. Of course, Dr. Bhargavi from neurology, Dr. Ramesh from neurosurgery, along with Dr. Chandra, Dr. Gaikwad and Dr. Ajay from neuroradiology, Dr. Bal and Dr. Madhvi from nuclear medicine, Dr. Ashima from psychology, and of course our epilepsy surgery and epilepsy fellows and basic researchers. Thank you.
So maybe we can now close with the final comment from each of the panelists, starting with Simon, then going to Virginia, then Professor Ikeda, and then Professor Kensuke.
Thanks, Manjari. So it's a very good case, and the comments that I'll make in my presentation and the cases that Virginia will show in hers are really along the same sort of lines. And I'm certainly a very strong advocate of doing a temporal lobectomy and seeing how a patient goes. But as you rightly pointed out at the end, the family needs to be counselled about the high likelihood in this situation of dysplasia being more widespread and seizures recurring. I think what you have achieved, though, definitely is having stopped the seizures and hopefully stopped the associated encephalopathy and lightening the patient's drug load, is that this child's going to make huge gains. And typically when you're operating in the right area, doing the right thing, the seizures will stop for a while, and hopefully it's a long while. And then, if and when seizures recur, the family will be very quickly back to see you because they've enjoyed the accelerated development and the period without seizures, and certainly don't want to muck around with drugs. So hopefully they'll, if seizures, do recur. And one of the cases that Virginia will show, it was, very similar with a late seizure recurrence. So it's a good case.
May I ask one question?
Yes.
That's excellent outcome. Congratulations. After the surgery, I just wondering that how the EEG has changed with a long course. The patient presumably had the bilateral generalized or the lateralized mainly on the right side, but all the spike or the slow has gone or not?
We've got one post-surgical interictal, of course there are no ictype, so just a routine outpatient EEG, which shows a normal background and no discharges as of now. She is seizure-free, and we have actually tapered her topiramate and stopped it. Because that is the one which causes the language issues and all. So topiramate has gone off the board, and we are trying to reduce all the other medications based on a normalized EEG.
Thank you very much.
Any other comments before we go to the lectures? There is a question. There is one question, if I may put it across. It's from Dr. Inad from Philippines. And also one question from Dr. Bintoto from Indonesia. So the question is, based on MRI there are two areas of abnormality, one in the right frontal and one in the right temporal. So you're right. So most of the abnormality was seen in the right temporal, and there was some suspicion of abnormality in the frontal. But other investigations like the ictal SPECT, PET, as well as the MEG pointed us out very nicely to the right temporal. So we wanted to place the bets first on the right temporal, and we wanted to do a resection of right temporal and see how it goes. So yes, like Dr. Simon Harvey has put very elegantly, with stoppage of seizures, the patient is likely to make huge gains. And if she does have any seizures in the future, the parents would have a lower threshold to come and report back to us, and we could perhaps investigate furthermore at that point of time. So I think we're running short of time. So let's please go ahead for the next lectures being given by Dr. Simon Harvey and by Dr. Virginia. So I will request Dr. Kensuke, I will share my screen so he can give a short introduction to our faculty. Dr. Simon Harvey.
Okay. Okay. So the Dr. Simon Harvey, he's the clinical lead of epilepsy program at Royal Children's Hospital, Melbourne, and honorary research fellow at the Florey Neuroscience Institute. And he's the past president of Epilepsy Society of Australia and past secretary of the ILA Asian Epilepsy Academy and Commission on Asian Oceanian Affairs. And a past member of several ILA task forces related to pediatric epilepsy. And as already you know, so his experience in the pediatric epilepsy and pediatric epilepsy surgery is great, and we are looking forward to listening to Professor Simon Harvey's lecture. So please, could you start the lecture, Simon?
Okay, just navigating my Zoom here. Thank you, Professor Kensuke, for that introduction, and thank you for the organisers for the invitation to participate in this webinar. It's been very enjoyable. I enjoyed digging deep into individual cases, and the cases that we'll present will be done a little bit more superficially, but they really, I think, will go to make the same important points as the first case about localization and what to do with complex patients. So following on from the case presentation we've just heard, I'm going to speak to some basic principles about localization and surgery in patients with temporal lobe epilepsy. I'll be focusing on children and focusing on so-called MRI negative or MRI subtle cases like the one we've just heard. And I'll be really highlighting the important role of neuroimaging, both structural imaging and functional imaging. And a strong point I'll be making is that a lot of these tough cases can be done without intracranial EEG monitoring. Virginia will then go through a few cases and that will highlight approaches, both in terms of investigations and surgery in children harbouring temporal lobe seizure foci, networks, lesions, but presenting with subtle or no abnormality on MRI. And then hopefully we can discuss these issues further. So certainly when I think about, when I see patients who have temporal lobe epilepsy and certainly drug-resistant temporal lobe epilepsy, I'm much more interested to know what their MRI shows than to necessarily dissect their seizure semiology and their EEG, because a very important determinant of prognosis and management is whether the MRI shows a lesion or not. And the typical lesions that we see in patients with temporal lobe epilepsy are listed here. Most commonly developmental tumours and hippocampal sclerosis, patients with various forms of cortical dysplasia or malformations, a smaller number of patients with acquired lesions giving rise to gliosis and encephalomalacia, tuberous sclerosis that I won't be talking about, and then various combinations of these pathologies, particularly subtle dysplasia or subtle HS with developmental tumours and areas of encephalomalacia. The really important point here, though, is that finding lesions in patients with focal epilepsy of any type, including temporal lobe epilepsy, is important for several reasons. Firstly, it predicts that a patient is going to have drug-resistant seizures. It's highly associated. Having a lesion on an MRI accelerates referral to appropriate centres and in many cases simplifies the workup for surgery. And having a lesion, a visible lesion on MRI, in a patient going for epilepsy surgery is associated with improved seizure outcome. We move now to thinking about patients whose etiology of their epilepsy is not so apparent, given that their imaging is normal or relatively normal. Are a few important considerations here. The first is that the patients may well be harbouring cortical dysplasia. It may be a type 1 dysplasia like we've just seen, but some forms of type 2 dysplasia, most commonly 2A, can be MRI occult or at least MRI subtle. Another important consideration is whether the patient truly has epilepsy, truly has focal epilepsy, and truly has temporal lobe epilepsy. So a patient who has temporal lobe epilepsy with apparently normal imaging, one should be looking elsewhere in the posterior cortex, in the insular cortex, basal frontal cortex, in case that's the source of the seizures and the pathology. An important consideration these days, given the access we have to genetic testing, is whether the patient might have a genetic focal epilepsy. And this is a more important consideration probably in children than in adults. Protocoherin 19 and CDKL5, these are important causes of childhood epileptic encephalopathies, and they may present with focal seizures, particularly PCDH19. And we at least once a year we'll have a child in the epilepsy monitoring unit being worked up, an infant or a toddler with seizures, and that's what they have. These are the genes here associated with familial frontal and temporal lobe epilepsy. The genes giving in the mTOR pathway are associated with cortical dysplasias, but also focal epilepsy without cortical dysplasias. And these are not necessarily deterrents to operate. Many of these patients will have surgically remediable epilepsy. These are some genes associated with focal malformations. Professor Akita mentioned ring chromosome 20 syndrome. And then there are some important genes associated with metabolic derangements and channelopathies. So these are we're thinking about in patients who have drug-resistant focal epilepsy in whom imaging does not show an epileptogenic lesion. And then we're left with patients in whom no cause is found. This imaging you're looking at here is a child that we saw and operated on several years ago with focal seizures, very clearly coming from the temporal lobe on video EEG monitoring, associated with quite prominent left temporal hypometabolism, and went on to have a temporal lobe resection. Surgery made no difference in that patient. The patient continued to have seizures and the pathology was negative. It's only several years later, just in the last 12 months, that one of our research groups looking into patients on their tissue found the germline mutation when in CDKL5. So clearly the reason why this child's continuing to have seizures. So the ideal patients that we like to see for temporal lobe surgery are patients not like the one that Manjari presents, but patients who have typical focal seizures of temporal lobe origin. So they have seizures in which they're still and staring and have maybe just some simple automatisms and ideally have an aura that's suggestive of temporal lobe origin. And when we do their EEGs, we see unilateral interictal discharges, epileptiform discharges. And if we're doing video EEG monitoring, we're recording localised unilateral anterior mid-temporal ictal rhythms. As I said, we like to find a lesion on MRI, and it's nice if that lesion is a very discrete epileptogenic lesion like a tumour or a cadenoma. Better still if it's in the anterior temporal lobe and away from the limbic structures. If there's cognitive or behavioural problems, it's better if the psychologists tell them that they're consistent with the Lobe and lateralization of the patient's seizures and pathology. And if we're doing any extra investigations, which are not always necessary in such patients, that they're concordant in terms of localization. We'd like the epileptogenic zone or the lesion that we're targeting and the surgical corridor to be away from important functional areas. And ideally a family that's on board, very well adjusted, understand everything we're putting to them and have the appropriate supports. Now, unfortunately, they're not the typical patients. The typical patients that we see, particularly in paediatrics, like Manjari's just presented, is a patient who has bilateral motor manifestations, sometimes even epileptic spasms and tonic seizures, no aura. Their EEGs show bilateral interictal epileptiform discharges, or frankly, generalised discharges. And when it comes to their seizures, diffuse low voltage fast patterns, and many of these patients would fit into categories that we would call an epileptic encephalopathy. Often their lesions are not present on MRI, or if there's a lesion there, it's subtle or has very indistinct boundaries. And if a PET scan is done, there is extensive hypometabolism seen extending out of the temporal lobe and even bilaterally. These children often are not cognitively normal, and they might often have delays in their development, global intellectual impairment, and quite significant behavioural problems that are clearly not specific to the temporal lobe. So Manjari's patient had right temporal lobe pathology, but right temporal lobe pathology does not cause that cognitive behavioural phenotype that child had. That child's developmental problems were due to the generalised epileptic encephalopathy that was going on. And many children that we see, we are considering they may in fact need very large resections, again, like the patient that we just saw. And then you can add to that the technical limitations and the challenges that face the surgeons when operating on infants and young children. And many of our families have often had a very difficult journey to get to see us, and it's a lot of work with these families getting into surgery. So if we think about possible approaches to patients that have lesional temporal lobe epilepsy, these are usually patients who need fairly limited preoperative workup and typically don't need to have intracranial EEG monitoring. I think most would agree that a child who has got fairly typical mesial temporal lobe epilepsy with hippocampal sclerosis just undergoes a formal anterior temporal lobectomy and amygdala hippocampectomy. I don't think there's many centres doing selective amygdala hippocampectomies in children. But if we're seeing a child who's got a temporal lobe tumour or cavernoma or a FCD2B, very localised lesion, these are the patients that most places would commonly just do a lesionectomy. And the studies show that gross total resection of epileptogenic lesions has a very strong association with seizure freedom. And this is certainly the approach to take if the localization is concordant, there's no contraindications to surgery, and as I said, the lesion is single and discrete. There are situations, though, where you might consider taking a cortical margin, or where you might consider performing a lobectomy even. And this would generally be appropriate if you're in the non-dominant temporal lobe, or certainly well forward of important language structures on the left. If you're dealing with a large lesion, say a large DNET or some encephalomalacia, which is fairly extensive, or perhaps even if after your lesionectomy, the ECOG shows prominent rhythmic spiking around the resection cavity, and it's not all over the hemisphere, but in a localised area. The other question that comes up is whether to do an amygdala hippocampectomy combined with your lesionectomy or lateral resection. And this is certainly appropriate if the hippocampus looks sclerotic or dysplastic on imaging. If the lesion is parahippocampal, abutting the hippocampus, it's very likely that the limbic structures will be involved in the seizure networks. If you're in the non-dominant temporal lobe, in the right temporal lobe, that's certainly fine. If the neuropsychologist tells us that the patient has a material-specific deficit in their associative memory, or if the patient has a significant intellectual disability, they're probably not going to miss their hippocampus. And if in the process of doing your lesionectomy lobectomy, you're able to access the temporal horn and record from the hippocampal gyrus, if it does show prominent rhythmic spiking, that might push you over into including the hippocampus in that resection. So turning to these patients like we've just heard about, who have either no lesion apparent on imaging or the lesion is very subtle. And these are patients who would certainly need more investigation to gain greater certainty about localization of seizures and localization of eloquent function. So these patients will undergo video EEG, PET, SPECT, and so forth. These patients need very good imaging because many patients that we see said to have, and their outside imaging doesn't show an abnormality, but with high field imaging, with special sequences post-processing of their scans, one can sometimes appreciate a subtle lesion like a bottom sulcus dysplasia, or very diffuse subtle change like we saw in the patient presented. We need to think about genetic causes in a patient with normal imaging, particularly if the phenotype is suggestive. And the approaches in these sort of patients, I think you can think about either doing a formal temporal lobectomy with or without resection of the medial structures, as was the discussion and the approach taken in the patient that was presented, or could maybe look at doing an ECOG and maybe functional imaging guided tailored resection. And this would be appropriate if, again, the localization is good from clinical and EEG to one temporal lobe. There's not concerns about the other temporal lobe. If there are subtle abnormalities on MRI and PET and SPECT, that these subtle abnormalities are all concordant on the same side and ideally in the same lobe, and particularly if it's all up the front of the temporal lobe. And if the patient could tolerate a large temporal resection like the patient we just saw, typically a patient who's got significant cognitive impairments. Might just add the point here that in patients that presented like the one we just heard about, if we see these children in infancy, often when the imaging is really indistinct, that sort of presentation with good lateralization and particularly temporal localization, we would think about doing a TPO disconnection in a patient like that to really maximise the chance of stopping the epileptic encephalopathy and hopefully not letting it come back. There would be situations where you might think in this sort of setting to do intracranial EEG monitoring, and that's certainly a consideration. And then some might say, well, maybe no surgery. But I think I'd make the point, like others have in the discussion, that most patients can tolerate an anterior temporal lobectomy, particularly if it's sparing the medial structures. So sometimes it's a cop-out, particularly in patients with an epileptic encephalopathy in a severe way like this patient, not to do something because it looks to be more widespread. Think about at least doing a temporal lobectomy. Just a few comments about intracranial EEG monitoring. I think it's uncommonly needed in children with temporal lobe epilepsy, especially lesional cases. You might consider doing intracranial monitoring, be that subdural or stereo EEG, in older patients with normal cognition, particularly if the MRI is negative and you've really got imprecise localization, particularly if there's concerns that posterior cortex, other extratemporal areas might be involved, or there's bilaterality concerns. And then patients who've got multiple lesions like sclerosis or complex malformations like polymicrogyria or periventricular nodules in their temporal lobe, or patients who've got a sort of complex injury affecting their temporal lobe, like some patients with poor encephaly post-stroke. So for localization, it might be needed, but I think it's rarely needed for functional localization. I think we can gain much information about language lateralization and even localization and where visual cortex and pathways are from functional imaging. And you can actually infer in many situations whether cortex is likely to be functional or non-functional from whether the MRI is normal or the cortex is damaged there, and whether it's metabolically normal or metabolically void of activity. And a good neuropsychologist can usually deduce whether a patient is at risk of having memory deficits from having their medial structures resected. And I don't think many places would be doing WADA tests in children. Now, it's worth keeping in mind that for tough cases, intracranial EEG monitoring really makes a really tough case clear. Often when you're inside the brain and recording EEG from the cortical surface, particularly multiple regions, you see very complicated patterns. I mean, it's good for distinguishing a hippocampal onset from a neocortical onset, but rarely do you get really exquisite localized intracranial EEG findings. If you do, it's typically in a patient with an FCD2 that hopefully you could see on imaging. This might be a patient you would consider for intracranial EEG monitoring. So it's a child, it's actually a teenage boy, an older boy, focal seizures of left temporal lobe origin. He had hippocampal sclerosis. But what was a bit concerning was he didn't have any antecedents like febrile convulsions. He had a lot of convulsive seizures, and he had a lot of insular type features, a lot of gagging and retching and salivation. And we were concerned about his insula. And we know that medial temporal lobe seizures propagate to the insula, but they're really, really prominent in this boy. His PET showed, in addition to medial temporal hypometabolism, concordant with his hippocampal sclerosis, it did show some relative hypometabolism in his insula. So we actually did elect to do intracranial EEG monitoring. It was done in a hybrid fashion. So here's some depth electrodes inserted into the hippocampus and the insula stereotactically, followed by subdural grid and strip electrodes around the around the temporal lobe. So this was the implantation, a fairly standard subdural implantation for temporal lobe cases. We used to do these a lot many, many years ago. We rarely do these now, supplemented here with some depth electrodes. But in this boy, from a localization point of view, the language mapping showed, localized language where it was expected in his superior temporal gyrus posteriorly, and there was concordant activation on his bold fMRI that we did prior to the surgery. And as far as his seizures went, they arose in his hippocampus and propagated to the insula as they commonly do. So we ended up having a left temporal lobectomy with a midlobe hippocampectomy. So the sort of operation you would do without intracranial EEG monitoring, which in our experience is often the case. So these days, we're much more commonly relying on functional imaging to localise functions. So we use functional MRI to commonly lateralise language and occasionally to infer localisation about language. So here shown in a patient who's got a superior temporal gyrus cavernoma. So a combination of paradigms, very generous thresholding to show us areas that seem to be involved with language. And we combine that with advanced tractography. This is not DTI, right? This is superior methods of tractography showing the various components of the arcuate fasciculus and here the optic radiation. So this is what we use to do our functional localization. Just very quickly to say where I'm coming from for the cases that Virginia is going to speak about. This is just looking at the last 10 years. I've already just quickly looked through our numbers. So in the last 10 years, we've operated on 330 children and adolescents. 158 of those involved surgery in the temporal lobe. That's excluding hemispherectomies. But 94 patients had surgery that was confined to their temporal lobe. So this excluded temporal plus posterior resections, extratemporal resections, excluded patients with TS who had multi-lobe arch eberectomies and excluded TPO disconnections. So there were 94 patients. 10 of those were patients who either had a previous epilepsy operation or had another one in those 10 years. Importantly, only six patients had intracranial EEG monitoring. We only do subdural EEG. We don't do stereo EEG. The age was spread pretty evenly across the span there. Not many infant cases, but many thereafter. This was the pathology breakdown. So in those 94 patients, so the most common pathology was, and these categories here are based on combined imaging and histopathology. So there were 29 of the 94 had developmental tumours, small number with hippocampal sclerosis. The focal cortical dysplasia group made up about 29%. So it's a smaller group than in the extratemporal series, and that's common in children and in adults. These patients up here with obvious lesions, so they were MRI positive, they typically underwent lesionectomies or lobectomies on the same sort of thinking that I mentioned in the previous slides. These patients down here with sort of negative imaging, non-specific imaging, type 1 dysplasias, and some of the 2A series, they had very subtle or negative MRIs and had either lobectomies or tailored corticectomies. So our approach at the Children's Hospital in Melbourne for patients like Manjari presented would be that we would suspect a patient like that had an FCD1 or an FCD2A, but I wouldn't be thinking 2A in that particular patient. We'd be getting concerned about a possible genetic basis, so these sort of patients would routinely have genetic testing done. We go back through their EEGs. Often when they present to us, their EEGs are horrible. I want to go back and look at early EEGs and find those early EEGs, because that's often where the focal features are present to give you clues. We'll do video EEG monitoring. We rarely do SPECT now. We do very high, quality MR imaging, and we do PET a lot now. We have got a combined 3T MRI PET scanner, so it's a very good scanner for paediatric epilepsy imaging, and we have a group of scientists that do our image processing. We'll infer localization of language and lateralization of language from their handedness and expected anatomy, where things look normal or abnormal on PET and MRI. And then we'll supplement that if the child's old enough and cooperative with fMRI, but all children can have SLF tractography done. The risk to memory, our neuropsychologists will tell us about based on their assessment and what the hippocampus looks like on MRI. And then basically what we're doing, like we were thinking about in the case that Manjari presented, is this a patient that we might do a TPO disconnection in, or should we do a more localised anterior temporal lobectomy with or without amygdala hippocampectomy, or is this a child that should have just a tailored corticectomy? And if we're doing a tailored resection, we work this all out before the child goes to surgery. So what's the minimum we'd like to do, and then based on the imaging, and then what's the maximum that we would do, again, based on imaging, where we'd be happy to go up with anticipating that we might modify the surgery with intraoperative electrocortography. So I'll finish up there, and I'll hand over to Virginia to present some cases, and then I'm sure we'll have time left for discussion.
Thank you very much, Simon. Yeah. So, shall we take some the questions or comments before the Virginia's presentation, case presentation?
I think we should, because that would keep the things in perspective. Maybe a couple of questions.
Is there, first of all, is there any questions or comments from the faculties, Sarat, Manjari or Akio?
I think Simon's presentation was wonderfully in sync with what you presented, and it has provided the viewers a complete spectrum of the challenges which is put up for cortical dysplasias, especially in pediatric age group. So I think that has completed the dots. It has joined all the dots. So there are a couple of questions from the chat box.
Yeah.
Maybe other faculty can comment, and then.
So I just wanted to say that many, just like Simon said, very often these children end up having serial MRIs and serial EEGs and serial discussions. Discussed several times in our pre-epilepsy surgery conferences. And they are really the over-explored and over-discussed patients. And sometimes, it is difficult for parents to understand why we've done all the investigations and not rushing them into anything. So very often these subtle lesions are the ones which we take our time in. So eventually in a child, you don't want to take too long because of the encephalopathy. So Simon, thank you for your excellent discussion.
And Akio?
Yeah, may I ask another question? Dr. Simon Harvey mentioned that the TPO disconnection for the Lennox cluster syndromes. So the temporal-parietal occipital junction could be the very important area for the multimodality integration function. So what do you mean by TPO disconnection? It is just a matter of a disconnection surgery sparing the associated parietal area. Would you mind if you explained a little bit?
So it's an operation that we do commonly, and most paediatric epilepsy surgery centres that are certainly busy would also do. It's essentially half a hemispherectomy. So it's a disconnection basically up the Sylvian fissure and then up the post-central sulcus. So it disconnects the temporal lobe, whole parietal lobe, and whole occipital lobe. Occasionally, we have patients where the disconnection will go into the central sulcus, but it's a motor sparing procedure, and it's a procedure that we would do in a child with spasms, tonic seizures, regression, where there are often subtle EEG, subtle MRI, subtle PET changes to one hemisphere, not necessarily in the posterior cortex. It might be that we're suspicious that the patient's going to need a hemispherectomy, but there's a bit more weight to the back, and we would do a TPO disconnection. And in my experience, that operation in those patients is much better than doing the operation that Manjari's patient had. And we've got a similar patient that we'll present, where you see something on the MRI and you're very tempted, or the PET, it looks quite focal, and you're tempted to do a small resection. But in fact, you're doing the patient a disservice. I'm talking about these infants and toddlers, because seizures are going to come back, and their older imaging is going to show more widespread changes, and they're going to need a bigger surgery, but they will have lost more. So giving them a hemianopia is nothing if you spare them from intellectual disability and autism.
Thank you very much.
Okay, so one question from a chat box. So how reliable is ECOG, electrocognitography, in temporal lobe surgery?
I mean, I think it's very reliable, but you need to pick the patient. So Virginia's going to show cases where we used electrocognitography, and if your patient has focal epilepsy and focal changes on their EEG, and you suspect they have a focal cortical dysplasia, then ECOG is going to be very useful. If it's a patient who's got a DNET or hippocampal sclerosis, A, they don't need corticography because their operation is already prescribed, and B, you'll just see discharges around the place. So those sort of scenarios gave ECOG a bad name. But ECOG is very useful in cortical dysplasia cases if the patient has a focal epilepsy EEG in their evaluation. Conversely, if the patient has a generalised type epileptic presentation with spasms and EEG changes like we saw in Manjari's patient, when you go in to do ECOG, you're going to find spiking everywhere. So if you record over the frontal lobe and over the parietal lobe and over the occipital lobe, so there ECOG can often not be helpful at all, and you need that backup operation that you're going to do, which is either a standard temporal lobectomy, or maybe it's a petectomy or something like that.
True. We find intraoperative ECOG very useful in dysplasias, and we do see a lot of gliotic lesions which show spikes, just like in runs. So both conditions. The only condition in which we do prefer it in a DNET is where we're not sure whether we should be removing the hippocampus if it's very close to the hippocampus. That's where we do it in DNETs, and we virtually don't do it in mesial temporal sclerosis. Yeah.
I agree with all those comments, and the gliotic patients, an interesting group. It's often at the rim of poor encephaly, or at the that you'll see with the gliosis, where you'll see rhythmic spiking, and occasionally the pathologist will even show you cortical dyslamination there. So it probably is a sort of an acquired dysplasia phenomenon, but giving the same ECOG signature. So I agree with those points.
Okay, thank you. So Sarah, can we proceed to the Virginia's presentation? Okay. Okay, so let me introduce the Professor Virginia Maxner. So the Professor Virginia Maxner is a world-famous pediatric neurosurgeon. And now she's a consultant neurosurgeon at the Royal Children's Hospital, Melbourne. And she's the current chairman of the Education Committee of the Asian Australian Society of Pediatric Neurosurgeons. And she was the director, Department of Surgery, there from 2001 to 2020, last year. And she has had over 20 years experience in the field of pediatric epilepsy surgery and pediatric neurosurgical education. So I'm very looking forward, expecting the nice lecture from Virginia. So Virginia, please start.
Thank you very much, and thank you for the opportunity to talk at this webinar. I'll just get my screen. So my talk is actually going to follow on from Simon's, just to highlight some of the points that he made. And the first point that I actually wanted to do was actually just to give some overarching comments about temporal lobe surgical procedures in children. So unlike your adult group, where majority relates to hippocampal sclerosis, the spectrum that we see of pathologies in children is quite marked. And so our procedures in the temporal lobe range from anything from an anterior temporal lobectomy with resection of medial structures. It could be very confined to a lesionectomy. It could be more extensive and combine an anterior temporal lobectomy and extend along either of the basal surface or more posteriorly. Or as Simon discussed, it could be a temporoparietal occipital disconnection. And what this means for the surgeon then is that when you're starting out to do the temporal lobectomies, it's all really a question of exposure. So this is a sort of typical incision that you might contemplate for a standard anterior temporal lobectomy. But for something like a TPO, you need much more room because you have to get all the way from the vertex down to the pterion. And this is probably one of the more common sorts of incisions that I tend to employ. And that's because in this group, what it allows us to do is to extend a long way back along the temporal base, which is very useful if you're trying to do very extended of those really sort of basal temporal dysplasias. The other thing that the surgeon must go into surgery knowing is they have a very clear idea in their mind of the anatomy of all the eloquent structures. So for language, that means not just an awareness of where the language is on the cortical surface, but also an awareness of where the deeper tracts of language would lie. And we utilize tractography and functional for most of our children of a suitable age. You also need to be aware of where the visual pathways lie, and in particular, not just concentrating on Meyer's loop anteriorly, but if you are going to extend a long way back, you need to start being aware of the optic radiation to avoid a heminopia if that's the goal. And prior to entering into surgery, a decision has to be made about whether you are preserving hippocampus and memory structures. And this is particularly if you are extending a long way basally. So I'd now like to present 3 cases which highlight some of the points that Simon made. The first is a 16-year-old right-handed young man whose seizures started when he was 15 years of age. He has an episode, they start as déjà vu, and if he's speaking, he will develop incoherent speech. If he's not speaking, he will be unable to talk, and he may or may not develop incontinence. These are very short events. They occur multiple times a day. He's already failed carbamazepine and is currently on lamotrigine and topiramate. And there's a family history of benign Rolandic epilepsy in his sister. His EEG shows background left temporal slowing. Interictally, he has discharges of a left anterior mid-temporal sharp slow with frequent runs of transient rhythmic delta. He has an ictal rhythm in the left temporal region, maximal at T3. His neuropsychology confirms that he has intact verbal memory, although there is some poor receptive language. And when we look at his MRI scan, the MRI is essentially normal. You could argue that maybe his left temporal pole is a little bit smaller, but in reality his MRI is normal, and this includes his hippocampus. So as we extend back, the hippocampus is normal in volume and other sequences normal in signal. His PET, however, is quite markedly hypometabolic in the temporal pole, which you can see here. And so, and his functional MRI shows that he has left language lateralized. So in summary, we have a 16-year-old who has an MRI normal, PET positive, language dominant, memory intact. So as a starting point with is looking at all his imaging data in a 3D space. So his T1 reconstruction of his brain, his functional MRI data on a very low threshold showing his frontal lobe activation, but also his temporal lobe activation and showing that it's quite posteriorly situated. We can determine the position of his optic radiation and his PET hypometabolism, which predominantly involves the temporal pole, but does extend back along the superior temporal gyrus. So in this patient, you could argue to implant him. However, pragmatically, we are not intending to give this young man a deficit. And so, but our experience and the PET hypometabolism and the EEG concordance, we plan for this young fellow a left temporal lobectomy with a view to preserve his hippocampus. We will design it to be anterior to his language, anterior to his optic radiation, and predominantly a PET resection. So a simple line that we could draw in the sand is this. And then we use intraoperative electrocortography to determine the boundary, was whether or not we need to extend it more posteriorly. So taking him to theatre, this is a sort of view that we have from a surgeon's viewpoint. This is again the 3D reconstruction, now orientated in the surgeon's view. So this is anterior, this is the middle craniofossal floor, this is his sylvian fissure and frontal lobe. This I'm pointing out is his central sulcus. We do this by mapping the 3D images to what we're seeing intraoperatively. And so we're looking at the anatomy that we're seeing here. We can identify those and match what we're seeing on a cortical view to our preoperative 3D images. This is the position of his language bulb anterior limit. And one of the important features in children is that most of our standard rules that we apply to an adult population for language and safe temporal lobe resections is a 4 centimetre rule, and these do not apply in very young children, and we'll highlight that in the next case. So a safe surgical resection line would be this. Language is here, optic radiation probably ends about there. A maximal proposed resection line would be something along this, which is now along the PET boundary. And a 4 centimetres in relation to the central sulcus. You can see 4 centimetres is safely in front of the central sulcus. We then do intraoperative electrocortography. And what this essentially shows that in this region of the temporal lobe, the background is essentially normal. But as the electrode courses over the temporal pole, we see attenuation and we see spiking in the anterior temporal region. Similar view, this is now more along the base of the temporal lobe. Again, these electrodes here have a more normal background, but over the temporal pole, there is attenuation and spike wave discharges and polyspike waves. And so his margin is essentially about 3 centimetres from the pole. This is our proposed resection line based on the electrocortography. This is now after that resection line has been achieved. And this is now electrode passed back along the parahippocampal gyrus. And what you can see is that there is still spiking, particularly we see here in electrode 5. So this is attenuation at the resection margin and ongoing spike wave discharge. And so that resection margin is now extended to include those electrodes, but limiting any further resection so that we avoid injury to hippocampus. That's the surgery at completion, and you can see there's been preservation of his hippocampus, parahippocampal gyrus, and his pathology is negative. He is now 2 years post-op and seizure-free. He's finished school. He remains on a single agent topiramate. The second patient is very similar to the patient that was presented. This is a 3-year-old who had seizure onset at the age of 12 months. These were staring episodes with head drops. The child would become unresponsive. She would have tonic and atonic seizures occurring multiple times a day, associated with developmental regression from the age of 14 months. He's failed multiple medications. His video EEG shows a poorer posterior dominant rhythm on the left. He has focal left mid-posterior temporal interictal epileptiform discharges, with left leading right sharp slow wave discharges. And his ictal EEG shows left greater than right bitemporal generalized paroxysmal fast activity. He has his neuropsychology shows that he has an intellectual deficit, being now at the age of 3, having a functional age of around 7 to 12 months. When we look at the MRI, at first glance, it looks relatively normal. However, at closer inspection, we see a similar thing as we were seeing in the case presented, and that is that you can see there is an abnormality on the left basal temporal lobe involving the hippocampus, the parahippocampal gyrus, and the fusiform gyrus. And you can see the high signal on the flare. And this abnormality extends a long way back on the basal temporal lobe, at least to the level of the splenium. Remarkably, however, the PET was in fact normal. It did not show any hypometabolism, and that was a surprise in this child. So this child is a 3-year-old, has MRI subtle, PET negative, cognitively delayed, and language is unknown because the child's too young. So this was one of the cases that Simon highlighted, that if we had not seen that focal abnormality, this child would be a candidate for a temporoparietal occipital disc connection. However, we had seen it, and so our focus was drawn towards that. So our plan in this child, very similar to the case that was presented, is a left anterior temporal lobectomy to include the basal and the medial structures which appeared abnormal on the MRI. So we did have an MRI boundary, but that we would guide that resection with electrocognitography, both to determine the degree of lateral resection and also basal resection. And we go into these sorts of cases with a knowledge of where eloquence might be. So it is possible, if we're doing a very restricted temporal resection on the lateral surface extending on the base, to avoid the optic radiation, and putative language is less of an issue in this child. Again, this is our orientation in the surgical space. Again, we identify the central sulcus. And that's because if we go back 4 centimetres on a temporal lobe in a child, and this is more to highlight the point, that will take us a far way back towards what would normally be considered receptive language areas. So I tend to use the central sulcus as a posterior mark in these children, in very young children. Electrocognitography is done then to identify lateral boundaries. So this is on the superior temporal gyrus and the basal temporal lobe posteriorly. And you can see that the background in these areas is very normal with modulated fast activity. Over the temporal pole, however, it's a different story. There is attenuation of the background rhythms, and there is spike wave and polyspike wave. And this can be seen continuing on the anterior basal temporal lobe. So we now have a potential lateral resection line, and that's what we did. This is now well forward of the central sulcus, and the resection line down here. And then the lateral structures are removed. And in this child, that gave us access to the more medial structures. So we can now record directly over the parahippocampal gyrus, and you can see the same abnormal activity extending on the parahippocampal gyrus, which was then resected to what we thought was the margin of the MRI. However, after removal, you can still see that at a resection margin, there are the occasional spikes in this, and that beyond that, the ECOG is normal. So this was then tailored to include that contact of the electrode. One of the points that Simon made is in children where you have a generalized epilepsy or a symptomatic generalized epilepsy, the initial electrocognitography can be quite abnormal, widespread beyond the temporal lobe, for example. And this was this child's recording over the inferior frontal gyrus. This is not necessarily an indicator to remove the frontal lobe in this child, because once we resected the clear MR abnormality, you can see that this normalized. Sometimes in children, however, after surgery, particularly when this is widespread, this may persist and it cannot always guide resection. So this is the resection that was undertaken. It preserved a lot of the lateral temporal lobe posteriorly, but extended widely along the base to the back of the splenium. And this child had an FCD1. The child was seizure-free off medicine for 6 years, and then seizures slowly recurred. These were blank staring spells occurring about once a month. He remains with an intellectual disability with language impairment. And the last case that I just wanted to present is a 5-year-old girl who had seizure onset at the age of 2 years. These occurred as arousal from sleep with head version to the right. She would smile and grimace, and she would have asymmetric stiffening with truncal automatisms and clonic facial jerking. She had an initial seizure-free period and then ultimately relapsed, having failed multiple medicines. Her EEG showed slowing in the right temporal region. She did have polyspike wave in the right central parietal and temporal regions interictally, and an ictal rhythm at T8, P8. She was normal cognitively, if not into the high range. This is her MRI scan, and on first inspection, nothing was obvious to the eye. However, her lesion became quite clear on her PET. It is still, however, very subtle, but you can start to see this area of hypometabolism on the PET. And having seen it on the PET, we can now appreciate the area of abnormality on the MRI. And this is associated with abnormal sulcation in the middle temporal sulcus region, with blurring of the grey-white junction at its depth and a transmantle sign. So this girl has a bottom of sulcus dysplasia. This was much more evident on our 3D reconstructions of her PET. You can see the overlying anatomy, and then you can see the marked hypometabolism in the depth of the sulcus. We did tractography, which showed her optic radiation passing immediately below the lesion. So she is an MRI subtle, PET positive, non-dominant hemisphere, her language being left lateralized on functional MRI and cognitively normal. And her optic radiation passes deep to the bottom of sulcus dysplasia. So the plan for this girl is to resect the grey matter of the sulcus only. And this is to both an MRI boundary, but in reality, the extent of the resection is guided by the electrocognitography. And we chose to do a very limited resection of her grey matter in this region to try and minimise impact on the underlying optic radiation. This is now, again, the surgeon's view. And one of the important things is identifying the anatomy and the sulcus. This is where the 3D road maps that we create prior to surgery are absolutely essential for this. And what we do is we identify the anatomy on the 3D model. We can then translate the folds, the gyri, and the sulci, so we can be exactly clear where we are. We have a very, very clear roadmap where to go in. Electrocognitography is essential for these cases. The overlying strip may not show any particular abnormality. There may be the odd spike in this contact, but really all the money is in the depth. And again, you can see attenuation of the background rhythms with spike and polyspike wave discharges. And then surgery is resection of the grey matter only, to no longer see those discharges. And so this is a very limited resection. It's about 2 centimetres long. It's about 2 centimetres deep of the grey matter only. And at the very base, you can see the transmantle sign. And this girl had a very clear FCD2B on pathology. So what we've done is just highlighted 3 cases of subtle MRI abnormalities across a range of surgical approaches. And then I'll hand this back to the panel for further discussion. Thank you.
Okay, thank you very much for your wonderful presentation. I'll pick some questions from this one. Does SEEG helps in children with focal pathology with generalized seizures and epileptic encephalopathy? Any case-based experience? So SEEG in child.
I can answer that not from the perspective of stereo EEG, but as we've highlighted with these cases, these children whose focal temporal pathology is manifesting as a symptomatic generalized epilepsy, so with spasms, tonic seizures, diffuse, often generalized EEG abnormalities. As we've shown, their intraoperative electrocortography, so their interictal EEG, often shows very widespread abnormality. And when it comes to their ictal rhythms, yes, it's possible you might show a regional onset, but very commonly you see in patients, in my experiences with, say, widespread subdural EEG, you just see these diffuse onsets, and they represent sub networks. So these patients, they've got focal cortical pathology, but their epilepsy, the electroclinical manifestations, are being driven by subcortical structures, and that's what you'll record. And I don't think these sort of patients, if that's their phenotypic presentation, intracranial EEG monitoring is going to help you. You're much more likely to be scared away from operating on the patient when you see these very diffuse patterns. The approach to these patients is to recognise the focal or regional or hemispheric changes on imaging and to do appropriate imaging-based surgery. And we've shown the use of intraoperative electrocortography, but don't take away from this that's essential. The essential thing is to do something, do it big, and do it soon in these patients. And if you don't make the patient seizure-free, you're very likely to buy time. And do something in these patients.
So stereo EEG is something which, at least for us, is an expensive proposition. In India, the out-of-pocket expenditure is huge for SEEG because the SEEG is not built into the program. The MEG is free, but the SEEG electrodes have to be paid for. So what we do is we try to maximize the non-invasive investigations by doing SPECT, by doing PET, by doing MEG, which is where we build up a hypothesis. If you have a clear hypothesis with a completely normal MRI and we know exactly, where we think it could be, which is not often the case in children, because in children you would see these generalized, pseudo-generalized and secondary bilateral synchrony and LGS-like picture even in focal lesions. So, if you have a clear hypothesis with which is based on maximizing your non-invasive investigations, then I think SEEG is worth it, but it's very labor-intensive in children. We've done far more adult SEEGs than pediatric SEEGs. So that's one thing. And then, of course, SEEG is not a fishing expedition that, you just go and implant wherever you want to, but you will have to zero down onto where you would want to. So that is something, and what we found more useful than rushing into SEEG is repeating an MRI before even doing the SEEG. So you've got an MRI before, and before you put in those electrodes, just repeat an MRI and then sit down with it and see it. So yeah.
Okay, and so this question is, I think, to Virginia. The examination of optic radiation and the language fMRI should be done as a routine preoperative evaluation in TLA cases.
It depends to a large extent about where it is you think you're going to be going in these children. And also the clinical state of the child. So fMRI in our institution is typically from 8 years and up, but can occasionally be done down to 7 and sometimes very rarely 6. So a lot of the children that we see are actually too young for fMRI. We would, however, do tractography. So we do that. And again, it depends very much on where you're planning to operate in the temporal lobe. If it is essential not to give the child a visual field deficit, for example, then yes, absolutely. A very young child, however, will cope quite well with an anterior temporal lobectomy and a quadrantic cut without any issues at all. So it depends on what you're trying to preserve.
Yeah. Okay, thank you. And I think this question is important for this webinar. From Indonesia, due to limited resources in my country, what type of epilepsy which could not be operated without ictal SPECT or MEG? Maybe for Simon?
Well, I think you would struggle with truly non-lesional patients, but we all struggle with patients who are truly non-lesional and we don't know where their seizures are coming from. You know, the majority of patients, particularly temporal lobe epilepsy patients, can be managed with good history taking, good video, scalp EEG, and then just a high quality MRI. And as we said, you're not going to cause a patient any problems doing a lesionectomy. You're not going to cause a problem in most patients doing a temporal lobectomy, as long as the surgeon can do those safely. So this is confined to temporal lobe cases. You know, if you were going to invest in something to expand your capabilities of epilepsy surgery, invest in high quality MRI and MRI interpretation.
So we have many questions yet, many more questions. So
I think we should take them because you know there's a wide audience. We see questions from Egypt, from Sri Lanka, so I think we should take them because yeah. Is it getting too late for you, Simon and Virginia, or
midnight?
Okay.
It's midnight and we go into summertime, so we tomorrow, so we lose another hour as well, but we're fine.
So with anterior temporal lobectomy, how to measure the extent, not the resection, depending on the age and the body weight of the child? And do we measure 4 centimeters from the tip or the central sulcus?
This question is from Sri Lanka.
Virginia would have to take it, yeah. So the question is whether there's a routine resection just 4 centimeters or you go to central sulcus, or, I mean, how do you determine the margins?
So if we're just doing a routine temporal lobectomy and you're in an adult-sized head, so older teenager, then your standard resections apply. So that's 4 centimeters on the left so that you avoid language, and it's 6 centimeters on the right so that you potentially will avoid a hemianopia of the optic radiation posteriorly. The problem with children, so if you take a young baby, 4 centimeters from the pole will take you well posterior and much too posterior to preserve language. And that's why those, if you look at an adult head, 4 centimeters from the pole typically puts you just in front of central sulcus. So I think if you're going to do it in a young child on a dominant language hemisphere, I tend to use that as my guide. Now, in a 4-year-old where you don't have functional MRI, you could have tractography. That still is a guess, but I think it's a reasonable line. I don't know if Sarat has a different experience or how he tends to draw the line in a very young child.
So you're right. So by and large, we go by that same rule, but we also use neuronavigation quite extensively. And we also do fMRI, which also kind of helps us to create the border of the posterior resection.
Can I say that most children having temporal lobe surgery, language isn't a great consideration. Most of the children, we're taking out DNETs and FCDs, and I mean, yes, I showed you a cavernoma sitting in the superior temporal gyrus, and obviously that patient, it's a very strong consideration. But I see a lot of questions in the chat there, and I just hope we haven't, put people off doing temporal lobe surgery. You can take a long way back on the temporal lobe in most patients. And so Virginia is highlighting, obviously, it's not so far back in a small brain on the left. But there are young children, if you had in a child who's less than a year or two of age, if you had to do a TPO disconnection, we would do it. We wouldn't avoid doing a TPO disconnection because we were concerned about language. If we're thinking of doing a TPO disconnection, and it's usually in a child who's lost their language and they're young and they're going to be severely intellectually disabled, non-verbal and autistic, and if we do a big temporal posterior resection TPO disconnection and maximise the chance of them being seizure-free, that actually gives them the chance to develop normal language on the other side.
So, yeah, there are some more questions.
The question from Egypt. How can we plan surgical procedure in patient with bilateral medial temporal sclerosis, but ictal recording showed left ictal onset only and PET left maybe a hypometabolic. Yeah, is it safe to proceed to ECOG guided without invasive bilaterally because it is not available in our country?
A lot of considerations there. A patient with bilateral hippocampal sclerosis is not a great patient to be operating on. I mean, you've got issues of seizure, localization, lateralization to consider, but there's also issues of the patient developing a global amnestic syndrome because their memory is probably not well supported. And if you take out, one or other, temporal lobes, their memory may fall in a heap and they're left with a global amnestic syndrome. So that's in a high functioning, they're probably not high functioning with bilateral HS. But, there are patients that are just a bit too hard. And, as a, broader sort of thinking about epilepsy surgery in our region, there are lots of children who don't get epilepsy surgery and who've got lesions and very, easy to fix problems. A patient with bilateral hippocampal sclerosis, epilepsy surgery would not be high on my list. And the resources involved with sorting out those sort of patients, bilateral intracranial EEG monitoring, potentially wider tests, that's a huge amount of work for a patient who's got very low likelihood of becoming seizure-free, high likelihood of having cognitive deficits, and not the best use of resources. And I certainly consider, the centre that I work in as a similarly, under-resourced centre.
Can I add something? Well, before we didn't know too much about autoimmune epilepsies, but over the past decade, every patient who has a bilateral MTS, we tend to, think that maybe in the past it could be a burnt out autoimmune. So we do autoimmune markers in these patients, especially the seizures associated. There's bilateral hippocampal signal change and there's cognitive involvement, and also there seizures in clusters. So, and sometimes because, surgery is lower down, we have also, given them immunotherapy, and few of them have responded. So bilateral hippocampal sclerosis, if it's truly bilateral, that is, the MRI is bilateral, the ictal onsets are bilateral, we do not rush into surgery at all, as Dr. Simon Harvey said. But if all the seizures are coming from one side, then it's not the best case you would want to take on. And really, if there's a lot to lose, like the memory is gone and both temporal lobes are impacted in terms of memory function, neuropsychologically, it's not an exciting prospect to just go ahead and remove the temporal. So really, these are lower down again on the surgical wish list.
So I think we have overshot the time. So we do have a lot of questions. Perhaps they could email us the questions. Jignesh, you could perhaps email us the questions with the emails of the people who have sent, and then we could ask the faculty to answer them and then send it back to them. So Professor Kansuke, with your permission, can I please summarize today's webinar?
Sure, please.
So we started off with a diffuse, I would say, a case of a generalized epilepsy in a child, 4-year-old child, who had large areas of PET hypometabolism involving the frontal area as well as the temporal lobe, which correlated to some extent with MRI, greatly for the temporal lobe, and to a lesser extent also for the frontal lobe. But in this case, the ictal SPECT strongly pointed out to the right temporal, and the MEG also correlated with that. This was an example of how we could maximize the use of non-invasive investigations. And after proper counseling, we went ahead and did a right temporal lobectomy with an extension behind the vein of Lobe. And the child till date seems to be doing pretty well. But Dr. Simon Harvey is also of the opinion that we could have also considered the possibility of a TPO disconnection, saying that our threshold for doing the surgery of TPO disconnection should be lower in young kids, because the prospect of having a hemianopia is much more lesser than the child having recurrence of seizures and epileptic encephalopathy. And very elegantly, both Dr. Simon Harvey and Dr. Virginia Maxner presented two categories of patients, which are MRI negative or having subtle changes. One with a focal cortical dysplasias, where he could do with a focal resection, plus or minus hippocampus resection, which again could be guided by invasive EEG. The other option being a large area involving the temporal, perhaps the adjacent areas like insula, occipital, and even parietal lobe, where we could have a prospect of doing a large resection. But Dr. Simon Harvey was more in favor of a TPO disconnection in such cases. So I think both the case as well as the lectures given by both of our faculty have connected the dots to provide a seamless knowledge about managing such cases. Now, with this, I will now request Professor Ikeda to say a few words before we close the webinar.
Yes, it is quite excellent and a very important discussion, even for adult epileptologists, because that pediatric epilepsy surgery is that one of the most important to prevent the development epileptic encephalopathy, and then the earlier the surgery is, that the better that to prevent the epileptic encephalopathy. So not only from the viewpoint of pediatric epileptologists, but also adult epileptists should be much more pay attention to that the importance of pediatric epilepsy. That's what I really feel at this moment. But we still have a lot of problem to be overcome in the future, like MRI negative, the focal epilepsy. But as the Professor Simon and also the Professor Virginia Maxner, as you mentioned, that there are so much the development of genetic analysis, even in the bottom of sulcus, which could be very promising. That's what I feel at this moment. Thank you very much for all of your excellent case presentation, the lecture. I really appreciate.
Thank you very much. We will meet for the next webinar. And I request both Dr. Simon Harvey and Dr. Virginia Maxner to also join us for the next webinar and also participate with us as faculty. So we are planning to keep all our ex-faculty also for panel discussion. So thank you once again so much to all of you. Thank you for all the participants. Thank you for all of you from various countries. I know it must be midnight in various countries, but still I see a lot of people attending this webinar, and have a safe weekend. Have a lovely weekend. Thank you very much. Bye-bye.